Welcome to Research Matters, the podcast where we discuss research matters and why they matter. My name is Joshua Davis with the Office of Research at Kennesaw State University. Today we're discussing how a research center at KSU is focused on improving the well-being of veterans and emergency service personnel. The Center for the Advancement of Military and Emergency Services Research, or AMES, strives to reduce suicide, anxiety, and depression amongst Georgia's approximately 1 million military and public safety personnel. In partnership with the Georgia Department of Veteran Services, the center has conducted more than 7,000 suicide assessments across Georgia. The center is also currently partnered with the Smyrna Police Department to improve both individual and organizational health. Joining us today is Dr. Brian Moore, Director of the AMES Center, and Dr. Bianca Channer, Clinical Director. Before we get into the conversation, here's a brief clip from Dr. Brian Moore discussing AMES impact.
One of the meaningful things I think about often is we've had numerous individuals submit handwritten notes to our group saying, your program saved my life. And that's just, it's very powerful, but also it's very meaningful for us because, a lot of times from a research perspective, it's ones and zeros. We're collecting data. But this is tangible evidence that what we're doing is working and what we're doing is making an impact.
Thank you both for joining us today. Brian, if you feel comfortable sharing some of your journey and how you got into this.
Yeah, so I spent a little over 15 years in the Army total, and I spent a lot of that time gone, traveling overseas, doing various Army requirements. So the last time I was in Iraq, I was an infantry officer total, while I was in the service, and I ran into a research psychologist, and I had been reading a lot of publications in science, trying to figure out why our Army programs were not as effective as I, who didn't know anything about science, thought they should be. And I was talking to this research psychologist, and he said, why are you talking to me about science? You're an infantryman. Okay, go do infantry stuff. And I just kept talking to him. And he put me in touch with the University of Texas Health Science Center at San Antonio, the Strong Star Combat PTSD Consortium, their director, who just, really I model a lot of what I do off of what he does. And for no reason at all, this guy who was unbelievably busy took my call and spent over an hour talking to me while I was downrange. And he said, look, man, if you want to learn science, leave the Army, come down here. I'll help you learn science. So I was post-company command. Yeah, okay. I was a pretty senior captain. Things were going pretty well for me, career-wise. Actually, I had a son. He was born, and I left for the first time when he was about a month old.
Okay.
And I was gone a long time. And so I left active duty, making over six figures to go be a grad student, which was high adventure for our family, I think. So went down to San Antonio, got my PhD in military psychology there. They have one of the very few programs worldwide that focuses on the military population, and I learned how to conduct research within the military, specifically within that infrastructure. Moved back to Georgia. So I'm originally from Georgia. To Kennesaw and started looking around. I said, well, who's doing military research or military relevant research? So when we look at Department of Defense funding mechanisms, usually it's focused on military or military relevant populations. My mom was a 911 supervisor.
Really?
So, I have that. My little brother's a firefighter. My other little brother's a Marine. It's a service is there, and the general idea of wanting to serve is there, kind of in me. And I started looking around. I said, well, who else wants to do this? And there wasn't a lot happening in Georgia at the time. And so part of the trust building is, well, if you've been there, done that, you have this sort of implicit trust until you show that you aren't worth someone's time.
Right.
And so, we built the relationships over multiple years, and we just kept showing up.
Bianca,
yes.
Why do you work with veterans? Why do you want to work with veterans? Assuming you do. You've been doing it a while.
I do.
Yeah, you've been doing it a while.
I have been.
Yeah.
I have a deep respect for them. I grew up in a military family. I've been
What branch?
Army.
Okay.
I have just seen a lot being a family member of
Yeah, thank you for
Army.
your service, because that's something I've realized. A lot of folks don't realize
the
Army families
serve too.
impact. Yeah. Yes, they do.
And so that drives it.
So how many years have you been at KSU?
Only 5.
Okay. Did you start this type of work prior to coming to KSU?
So yeah, I did. I started it in my doctorate program, but in that realm of things, I was looking at incarceration.
Okay.
And just, again, sort of very similar things, programs, policies, and how they impact persons who are incarcerated. We take a micro, meso, macro approach where we look at the individual, the micro, understanding that whatever is going on with that individual is because of the meso, the group, the workplace environment that they might be in, which then is impacted on a much larger level, or the macro level, which is the policies, the communities in which they live in. And so I think that's why we work so well together, is because we both come from that lens, different angles,
Right.
but same lens.
So the primary focus for AMES is to understand factors kind of within communities that influence health and well-being for military, their families, and also first responders. And so what we're looking at is historically about 50%, I say historically over the last 15, 20 years, 50% of veterans are engaged with the VA, which means about 50% are not getting that direct VA care. So it's not that there's a lack of access, but there's also a lack of engagement from veterans with the VA system. And so one thing that we're doing at AMES is helping individuals realize what their benefits are through linkages, as Bianca mentioned, also community engagement, what the community resources are, and then how to help them essentially have a life worth living. And so part of that is our suicide reduction initiatives and community well-being.
So coming back to families, how does that interact as a clinician in regards to treatment?
Well, I am of the belief that we can't just treat individuals. Individuals are embedded in families and communities, and they all are impacting each other. As a clinician, though, you kind of have to take a hat of you are working with the individual as a person first, and of course their family sort of secondary, or you are working with the family primarily, and that is your focus. So oftentimes in the individual side of things, I'll talk to people about, how they're engaging with their family. Are there things that they want to work on in their connection to their family members? So, I'm working with the individual, but focused on how they're showing up in their families. And when I'm working with families, it's a lot around how they're communicating.
The part of the reason why we do that, so as Bianca mentioned, we collectively are of the opinion that you should not work with one singularly affected individual. When an individual experiences stress, it does dynamically impact the family system and then also community. So there's sort of this ripple effect, if you will, of stress or trauma. Veterans, first responders, both, it's the same from my perspective, from a stress experience, don't want to share what happened that day or, at a singular traumatic event with their families. They try to protect them from it, which can create family dysfunction. And so part of what we do is we provide a safe space and then also an area with Bianca's team to help them better learn to communicate their experiences with their families so families understand where they're coming from. They're not caught out of the blue. And then also involve families in treatment, intervention planning, and then the focus again for our work is helping individuals have a life worth living from their perspective.
So is there any wonderful story that you guys just really realize the value that helps you get up every day to go to work? Is there any example that you'd like to share?
I have two examples that kind of readily come to mind. One is we are overseeing and partnering with the Georgia Department of Veterans Service on a Staff Sergeant Parker Fox grant. So Staff Sergeant Fox was an Army sniper who died by suicide. And so his family advocated to reduce suicide within the military and within our veteran populations. And we've had numerous opportunities to engage with them through this project. And it's been so meaningful to be able to engage with a family that gets to partner with us. Again, this is community-based work. And we say, what did you see? What are you looking for? How do we reduce, this type of incidents moving forward? And it's been very valuable to us. And then also one of the ways that we've applied a research perspective to this project, because the funding was not a research-based project, but everything we do has a research portion to it. So as we worked with the Georgia Department of Veterans Service, they have 55 field sites across the entire state of Georgia. So we're able to expand our reach, from our little AIM center across the entire state in every single county of Georgia. And we helped them being Georgia Department of Veterans Service, to better understand how to collect data, how to meaningfully collect data, and then also how to engage with individuals who are at risk for suicide, and then to transition those individuals into appropriate levels of care. And so out of that, one of the meaningful things I think about often is we've had numerous individuals submit handwritten notes to our group saying, your program saved my life.
Wow.
And that's just, it's very powerful, but also it's very meaningful for us because, a lot of times from a research perspective, it's ones and zeros. We're collecting data. But this is tangible evidence that what we're doing is working and what we're doing is making an impact. The other piece too, and this is kind of highlighting and bragging on Bianca's team that means a lot to me, our CDC project that we are running in tandem with the Office of Public Safety Support, and then also the Georgia Department of Public Health is focused on suicide prevention, suicide reduction in first responders. And then we also have an element of veterans that we're able to serve through that. And last year, we finished up year 2 with the Smyrna Police Department and had about a 50% reduction in suicidal ideation, 40+% increase in marital satisfaction, 40% reduction in stress. I mean, massive, massive impact. And we got really excited, but we said this is one of 40 agencies. We need to replicate this. We're good scientists.
So what happened there? Like, what was the discovery, I would ask?
So we start with an organizational health assessment. Bianca's team conducts a 4.5-hour intervention roughly throughout the course of a year.
Now, when you say intervention, that's with individuals?
That is with groups. We do group psychoeducational trainings quarterly, and then we do a individual wellness check.
Okay, and that's obviously self-selecting, like people volunteer to join, or?
So normally an agency will mandate their folks to be there. So in the state of Georgia, we're in an interesting position. And if any researchers are listening, hold on, I'm getting to the ethics part of this. So in Georgia, you have to do a specific number of continuing education credits essentially for law enforcement. And so we have gotten our entire curriculum certified through the Peace Officer Standards and Trainings Council. And so they get credit for showing up. They have to be there, but they don't have to participate in our data collection efforts. And so they get the 4-hour training block over the course of a year. So it's 1 hour every quarter where our team shows up, delivers trainings unique to that agency's concerns, and then 30 minutes with one of Bianca's clinicians. That's just a wellness check. It's not clinical work.
Right.
It's not therapy. And so at the end of that year, we do another organizational assessment, and we look at how they're progressing as an agency. And so it's a cohort assessment, which is flawed in many ways, but we replicated it with the Kennesaw Police Department here. So roughly same size, same geographic area. 72% reduction in suicidal ideation and a greater than 40% increase in marital satisfaction. We saw substantial reductions in stress, substantial reductions in financial challenges as well.
And how much time collectively per year? It sounds like it's very minimal.
4.5 hours.
Yeah, that's pretty
It's what we call
amazing.
light touch intervention.
Okay.
Yeah.
Wow.
And earlier you asked, do we have something that we can package and hand off? This is it.
Okay. So what do you do with the handwritten notes?
So I actually have a desk drawer full of handwritten notes. I'm not kidding. When I say full, there's probably 30 or 40 in there. And honestly, on days when I feel overwhelmed, I feel tired, I feel stressed, and I think, why am I doing this? I pull those notes out and I look at them. And I share them also. I'm not hoarding the notes like a little drag.
They are accessible.
But I do share them with everyone. And when I get a new one, I take it to our staff meeting and I read it as a reminder, hey guys, what we're doing makes a difference and it matters. I think one of the reasons we have been so successful in engaging with people is that we provide a human touch to what we're doing when we're engaging. When we show up, it's, hey, there's Brian, he's a person. Hey, there's Bianca, she's a person. Things of that nature. And so people, one of the biggest factors that we've identified in terms of suicide risk is actually a lack of social connection and loneliness. And so when we're showing up in person and we're showing up consistently in person with agencies, they begin to trust and they begin to work with us. And the same goes, I say agencies, but also for our veteran serving groups.
Mm-hmm. The project that we've been focusing on, these organizational health assessments, as Brian has stated, what has made it so effective is that we don't just hand people a QR code and say, take this survey, and we're going to keep this information at KSU and publish it in academic journals that people have to buy and, then decipher what exactly we are saying. We go back to the agency and we sit down with them and we go step by step by step over the assessment data with them. And then we ask them, okay, what are you guys interested in doing now that you know what is going on within your agency? We don't come in there saying, well, we're researchers and scientists, and I'm a therapist, and I know these things, and this is what your agency needs, and this is why your people are stressed out.
I know what's best for you.
Yeah.
So you're a partner, fundamentally.
Yeah. So I would hope that those partnerships continue, that we can be able to show. I mean, again, we're young in our journey here, but I would love to see us again, have more agencies where we can compare year 1 and year 2, where we can also see where there are other programs that are out there. Are they effective? I want to know. I'm curious.
Right, because the research landscape is massive for this, I assume. But the bringing it back, because I would say the paper wall, in a lot of cases, holds a lot of research. It's not accessible. To your point, bringing it back to them, that's unique.
It all needs to leave the center because it comes from the community. We have a deep belief that it needs to be back into the community.
One of the things, though, to highlight, kind of add on to what Bianca's saying is, we do also a lot of the academic dissemination of information. So we did 29 peer-reviewed publications last year. We had 10 students as co-authors on those papers. So one of the things that we're focusing on is building the next generation of researchers also.
Yes,
so we're getting undergraduates and graduate students. We have, I think, from 3 universities right now represented at AMES. We're training them to go out into the community and do these types of things. And then to make research digestible, we also have a blog that we run every month, and it's called AMES in Action. And we highlight and we take one of our peer-reviewed studies or one of our activities, and we make it at the 8th grade reading level, and we publish those. And then we've also partnered with a foundation, a national level foundation, to help us in disseminating our efforts and work across the country.
You and your team has just been building up momentum. My assumption is the momentum's not going to slow down. Are there any barriers externally to that momentum?
Our primary barrier is time.
Okay.
Quite frankly. So time and personnel. We have about 20 people kind of on payroll right now in some capacity, whether those are full-time faculty, full-time staff, interns, postdocs, things of that nature. And so, our phones ring off the hook. Agencies call. They want to have help. Veteran-serving organizations call. They need assistance. They want thoughts on whatever it is that they're doing. And so part of our constraint is time, but really I think the key that has been successful for us is, and as Bianca mentioned earlier, we don't go in and say, I'm a professor, I'm a doctor, I'm a scientist, I know what you need.
Right.
We go in and say, here's our skill set, we care, give us a chance.
How can we help?
We let a lot of our initiatives in science be driven by partnership needs.
And that makes sense, yeah.
So it's difficult to say. I mean, things literally change by the week, it seems like.
Yeah.
Last year alone, we did 85 outreach events. One of the outreach events was an event called the Let's Connect Summit, which is funded through the Staff Sergeant Parker Fox grant. And then last year we had the Department of Behavioral Health and Developmental Disabilities also chipped in and partnered with us to kind of expand the event. So again, our approach is always research-based, and we want to reach as many individuals as we can to ensure that community resources are available. So we did year 1 Let's Connect Summit here at KSU's campus, kind of working out the kinks, understanding who would come, who would be interested, things of that nature.
And you said 85?
85 outreach events.
Last year?
Last year, yeah.
That's a lot.
Well, we are very busy people.
I mean, that's at least once a week. It sounds like twice a week.
Sometimes multiple in tandem.
Sometimes all at the same time.
We have 3 today, actually.
Yeah, that's true.
So do they show up to the Ames house over there, or
No.
We are everywhere.
We travel all throughout Georgia and
everywhere. Bianca and I were in
Texas
yesterday. We have our associate directors currently in California.
You'll be in Florida
I'm going to Florida tonight.
Yeah.
So the Let's Connect Summit, though, we had the first year here at KSU. The next year we had it. We did a statewide assessment for suicide risk and then also resource availability. And we want to take the resource, the education, the opportunity to areas where it's needed.
Yeah, that makes sense.
So we had the second year in Columbus, and we had almost, a 50% increase in attendance. And then this year we're in Savannah, which is also a really hot spot for us from a suicide and resource allocation and need perspective. And so this year we're building on and adding continuing education credits.
Correct. For social workers, licensed therapists, et cetera.
We are currently working to write Georgia's or assist in writing elements of Georgia's strategic suicide prevention plan.
Does one already exist?
It does.
It does, yes.
But in last version, there was no focus on veterans or first responders. This year, AMES is leading the development of both of those for the next 5 years.
Yeah, I mean, I don't know the statistics, but my assumption is that's definitely a high-risk community relative to majority of the population.
We can tell you in the state of Georgia, suicide risk or suicidal ideation, rather, for both our first responders and veterans is double what you would see in the general population.
Yeah.
And when you start looking at risk factors, it's astronomical. So one of the areas that we focus on in terms of our national expansion, so trying to serve as many folks as we can, sort of more faces and more places, if you will, is we partnered with the Outer Circle Foundation. So they're a nationally focused foundation founded by a former Air Force Special Operations service member who's also a former police chief. So there's a lot of overlap with what we do, what he does. And so they do a lot of outreach, a lot of engagement. They have a vast network. And then we help provide them with scientific expertise for programs that they're interested in funding or partnering with. And in turn, they help us with referrals and then just providing scientific expertise. So it's a really symbiotic relationship. We've also partnered before with the Rosalind Carter Institute for Caregivers on a project, which was really great. Yeah. And then we have other groups that we partner with that are community-focused, like Community Building Artworks out of Maryland. Really just fascinating. And we're looking at what are individuals offering that is replicable and sustainable.
Yeah, that seems like that's hard, right? Because there's so much. I mean, my assumption this topic is so complex, so diverse. There's so much research on it, but the outcomes, measuring the outcomes, finding what works, and then repeating that as a system seems daunting. And it seems like you are doing what's possible at AMES.
That's why AMES was created, to do that.
Yeah, it's interesting. No one likes the one-size-fits-all T-shirt, I think. You know, and so
nobody fits in them either.
That's right.
Unless you're built like a cube. Now, so we go to agencies because it's one thing to look nationally and we say, okay, 5% of individuals nationally are experiencing financial stress. Okay, that's fine. But what about here in my community? If I go to Brantley County, Georgia, it's not 5%, it's 55%, it's 65%. And so a program at the national level would not be sustainable or even tenable for that specific group. And so that's what we offer is we say, hey, let's reduce that one-size-fits-all T-shirt to something that fits you and your unique concern.
I mean, you're the researcher, we'll say, Brian, but do you ever do the interventions the way she does? Like, do you actually sit down face-to-face? I'm assuming you do.
Yeah, actually, so some of the interventions that the clinical team delivers, I created.
Okay.
2 of them. So my earlier training had a heavy clinical focus, but when I left active duty, I was having a lot of neurological issues from a brain injury, and I found very quickly that my memory was not good for the type of work Bianca does. And so, I help develop interventions based on clinical science, and then I help refine and revise them as they collect the data and move forward.
As I was thinking earlier, what you guys are able to do is start to gather data that doesn't exist and get a lens onto reality. But then also you go and have impact and you gain from that. So you're starting to realize the research methods that can be used and work to then affect state policy. But how do you change that? That seems really complex.
It's actually interesting. We have been a part of numerous state policy discussions from the science side, from the data availability side. And so our efforts, we don't advocate, we don't lobby. We simply say, here's what the data says. Here's what the science says. Do with that what you will. We're not elected officials. We're nonpartisan. We don't get in the middle of it. We say, here's the data. But one real world example where we had a tangible impact is the Ashley Wilson Act, which was helping increase access to PTSD resources for Georgia's first responders, which was really an interesting step for us into the policy field. Another was assisting, and we partnered actually with the External Affairs Office, Dr. Tyler Reinagel on this, was helping the state better understand, again, from a policy and resource availability standpoint, where war veterans' homes could be located. And then we're also working at the national level with ours and other state senators and lawmakers, providing them information and data, again, at the national level on trends that we're seeing. And we've had 2 of those meetings with national level lawmakers to influence policy. Our demographer, Dr. Chris Hess in the sociology department, he has a national sort of view on housing programs, housing insecurity, homelessness, things of that nature. And so we do work with homeless veteran programs on many different capacities. But one thing I think that's a real world impact, last summer, the state of Georgia, the lieutenant governor commissioned a special study committee on veterans' health and wellness. And so Dr. Hess, the AMES demographer, the assistant professor in sociology, he was called up to the Hill to brief for, it was like 2 hours on data that we have collected at AMES on veterans, homelessness, risk factors, programs, where the VA's money going, how we could better allocate resources statewide to meet needs. That's one side. And then we also partner with Outer Circle Foundation on doing national level evaluations assessments for state needs. We've partnered with the Georgia Department of Veterans Service to better understand where housing should or could be placed for veterans in relation to war veterans' homes and things like that.
Well, thank you both for what you do. And what I love is the smile on Bianca's face is very clear that the impact is real.
It is. I mean, I get to hear it from individuals. I get to see it in policy changes. That's the best part of it. That's why I do what I do.